Dear colleagues, welcome to today's topic in the webinar series. We're going to talk about hypertension and atrial fibrillation, a risky couple, and even more so when the family expands. And today we have a great pleasure. Professor Angela Maas will share with us the forgotten partner of the couple, female heart failure. Professor Angela Maas is a clinical cardiologist and on a personal basis a very good friend since more than 30 years, and she has developed a main interest in heart disease in women over the past decades. She focuses on the early identification of women at increased cardiovascular risk and symptom evaluation in women at middle age. Please, Professor Maas, dear Angela, share with us your presentation about hypertension in women and the risks, especially for those over the age of 50 years old. Thank you. Look forward to your presentation.
Okay, thank you, Jeroen, for having me here. Well, hypertension in women is the most deadly cardiovascular risk factor and risk factor of all other risk factors globally. Here you see a slide, quite recent slide from 2 years ago. You can see that high blood pressure is the major deadly cardiovascular risk factor in women. And we know that there are many differences in the way blood pressure behaves during lifetime. In general, you can say that below the age of 50, blood pressure is higher in men compared to women. The men are the blue lines and the red lines, the purple lines are women. And you can see that after the age of 60 here, that systolic blood pressure rises more steeply in women compared to men. And the decline in diastolic blood pressure is about from the mid-50s downwards because of the stiffness of the blood vessels, that there is a greater pulse pressure. So at younger age, women more often have high blood pressure. At older age, it's more common in women. And there is some role of menopause in the rise in blood pressure in women, not necessarily in every woman. We know that the panel on the left, that estrogens are important in the downregulation of the renin-angiotensin system. And when estrogen levels decline towards the age of menopause, you can see that blood pressure rises, there's more inflammation, myocardial hypertrophy starts to develop, and the risk profile of women has a more adverse profile. And on the right side of this slide, you can see that specifically a younger age of menopause, below the age of 40, but also women having more vasomotor symptoms during menopause transition, that these women have a higher risk that menopause also enhances the rise in blood pressure. So if there is a more symptomatic menopause with a lot of symptoms, that may be also related to a faster rise in blood pressure. And it's often said that you don't feel hypertension. Well, this may be true for elderly people above 80 with very stiff blood vessels and a long-standing history of hypertension. But specifically in women entering menopause, women passing their 50s, hypertension may provoke a lot of symptoms. Think of fatigue, chest pain, pain between the shoulder blades, but also atrial fibrillation, paroxysmal atrial fibrillation, and extrasystolase, sweating, hot flushes. And often in those women, all these symptoms are attributed to menopause itself, whereas it may be a good reason to check blood pressure more frequently. And as I said at the start of this talk, the most deadly risk factor is hypertension in women. And we also know that hypertension is the most important cause to have atrial fibrillation. So this is a very important connection also in women. And Eva Gertz has chaired a very nice position paper last December in the European Heart Journal about sex differences in the development of hypertension. And it's important to notice that specifically in women, on the long run, there is more vascular stiffness compared to men. There's also more development of myocardial stiffness, HFpEF, and also more changes in the microvasculature with increased microvascular coronary resistance. These are important sex differences that occur in vascular and myocardial aging and also lead to more symptoms, specifically in elderly women. Think of dyspnea symptoms in women above the age of 70. And we know that about half of heart failure in women is HFpEF, and chronic inflammation, for instance, related to obesity or diabetes, or even hypertension, is involved in this process. And this is also connected again to microvascular dysfunction. So these are all closely connected syndromes. And when we think about prevention, it means that we have to start early with checking blood pressure in women at middle age. And there's an important pattern in remodeling of the left ventricle with aging. In women, hypertrophy dominates over dilatation. In men, we see more often and more early dilatation of the left ventricle. And many factors are involved. Again, the risk factors, as just mentioned, but also comorbidities, inflammatory comorbidities that we see more often in women. We call this risk variables, but also sex-specific gene expression with aging in the myocardium and blood vessels. And then there are also some differences in dominance of risk factors. It is important in women also to bear in mind that 1 out of 7 nowadays women has breast cancer. And often those women get chemotherapy that may induce early myocardial damage, but even also late myocardial damage about 20 years after initiation of treatment. Women may also have subclinical and clinical peripartum cardiomyopathies that are not always diagnosed. And in men, other risk factors may dominate more compared to women. But of course, there are also many common risk factors, but we have to take notice that there are differences in accents of risk factors among men and women. We published 2 years ago an article with endocrinologist and gynecologist about female-specific risk factors and the impact of those in cardiovascular aging in women. And one important risk factor related to hypertension and the development of atrial fibrillation are related to hypertension in pregnancy. About 12 to 15% of women will have high blood pressure in pregnancy. about 3 to 5% of those women have severe hypertension in pregnancy, preeclampsia, or a HELP syndrome. And those are the women that start having hypertension at an earlier age. We showed years ago that about 40% of women after preeclampsia already have elevated blood pressure around the age of 40. And this is not the age that women go to their GPs to check for their blood pressure. It's not in the guidelines, but these are certainly high-risk women to develop premature hypertension and also premature vascular aging. In women, there are still, of course, also in men, but specifically also in women, there are many barriers for treatment. In general, we still know that the socioeconomic position of women is less favorable compared to men. And we know also from data from the US that a lower socioeconomic status is associated with fewer preventive measures. There are, of course, also patient barriers related to education level. This also accounts for men, but in general, also single mom households. The mothers may be at increased risk for healthcare problems. And then, of course, there are barriers in the healthcare system itself. And one of those is clinical inertia. We tend to get used to high blood pressure, and well, we see so many patients with elevated blood pressure that we may be not alert every day to treat them as we should do. And of course, there are barriers in the system, expenses of medication, etc. And I like to end with a very high risk woman. This was a woman of age 41 who I saw a few years ago at my outpatient clinic. She had migraines since her teens, hypertension from 20 years onwards, 3 times a miscarriage, gestational hypertension. She smoked for several years, and at both sides of her family, she had premature hypertension. And you can see at the age of 41 that her blood pressure was really too high for her age, but she wasn't treated for that. We did a coronary calcium score because she had symptoms of chest pain, and we found a very high calcium score of more than 200 at the age of 41. So premature hypertension in high-risk women may lead to premature vascular aging, and these are the high-risk women that we as medical experts have to take care very early onwards. So patients themselves can also be very helpful by measuring blood pressure themselves. We're doing now a project in women with microvascular angina, and many of them also have hypertension, self-measurement of blood pressure, also nighttime changes in blood pressure may be an early sign of onset of hypertension. And there are nowadays many modalities that we can use, and we've seen that women are very willing to contribute to their own health. So in that aspect, women are quite easy patients. It may be more difficult when you try to treat them with medication, but for self-measurement, they are very cooperative in practice. So to conclude with, when we consider high blood pressure and atrial fibrillation and end organ damage, such as HFpEF, and of course symptoms like atrial fibrillation, we have to take the different life course of men and women into account. So after the age of 60, hypertension is more important. Systolic hypertension in women, a prior history of hypertensive pregnancy disorders is important. The onset of menopause is important, and also other factors, atrial fibrillation with aging, etc. And there are certain differences among women and men in the life course. So there are many similarities, but also differences. And I think in this area of patient-tailored cardiology, we need to check for those differences because it may be the patients may benefit from that. Thank you.
Well, that was a great lecture, Angela. Really fantastic. And it shows us, it teaches us that in women, there is a lot of attention needed for personalized medicine. You made that very, very clear. So I got two questions for you. The first one is, are there certain risks, certain risk groups of women that have a higher risk for premature hypertension? Can you tell us a little bit about that? Can you say, okay, these are the ones as a clinician you got to watch?
Yeah, well, I showed it a bit in my in one of my last slides. The women who start in their teens with frequent migraines. We know that premenopausal migraine is associated with earlier hypertension and cardiovascular disease. This is different from postmenopausal migraine, which doesn't seem to be related to a higher cardiovascular risk. And those women who have frequent miscarriages, from 2 times miscarriages, you do have a higher risk to develop hypertension. Of course, hypertensive pregnancies are at increased risk. So the life course is very important. And this is not only something for gynecologists to look at, but we as cardiologists, we should check for this. And these are some very simple questions, but very important for the patients.
And just an in between, you highlight again the multidisciplinary approach. We as physicians, as specialists, we have to connect more with each other than we used to do in the past, correct?
Yeah. I think innovation in healthcare nowadays is at the crossroads of the different disciplines. I think that's the most important because, when you look at the patient life course, the patient will have several health problems that may be related to each other within different medical disciplines.
Right. The multidisciplinary approach, as we talk about so often. So another question that comes up is, what is the role of self-measurement blood pressure in current practice? Can you advise us about that? How do we implement that? How do we bring that to our patients? What is the role of self-measurements?
Yeah. Well, we showed in a recent publication, we did a study in 200 women after a prior preeclampsia, and we randomized them in 2 groups. 100 women had usual care, and 100 women we asked to measure their blood pressure every month during 7 days a week. And these were women at the age of around 45 in general. And we saw that we excluded women already known with hypertension. And we saw that women who measured their blood pressure themselves, that 25% of those women detected having elevated blood pressure within a year time. So patients can be helpful to their GPs or other doctors to identify their hypertension. And we saw that it was feasible to do so. We also saw that 7 days a month may be a bit much on the long run, but women stayed motivated to check their blood pressure at least a few days every month. So patients can be very helpful to their doctor to bring the appropriate diagnosis.
I think that's a really important message that you put forward there, that you engage the patients to also partially take responsibility for their healthcare. But not only that, it shows also that just one blood pressure measurement is really not what you need. What you need is this big scala over the day. How does it oscillate? Where is the high level of blood pressures, etc., etc. It gives us so much more information. And again, self-engagement for the patient is important. Take your responsibility for your own health.
Yeah.
Angela, fantastic presentation. Let me thank you very much. And it was a great show. Thank you.
Thank you. Bye-bye.